Pulmonary angiography has traditionally been considered to be the gold standard in the diagnosis of pulmonary embolism. Digital subtraction angiography is the technique selectively utilized when a definitive diagnosis of pulmonary embolism or DVT cannot be achieved by less invasive means. This study, which requires right heart and pulmonary arterial catheterization with selective injection of contrast, can be performed safely in the majority of patients. The accuracy of pulmonary angiography in the diagnosis of pulmonary embolism is very high. Based upon clinical follow-up of patients with negative studies, the sensitivity of pulmonary angiography is 98 to 99%, although as with CT angiogram, the accuracy for the detection of subsegmental PE is only closer to 66%. Pulmonary embolism is diagnosed on pulmonary angiography when an intraluminal filling defect or the trailing end of an occluding thrombus is outlined by contrast. Secondary signs, including a prolonged arterial phase, diminished peripheral perfusion, and delay in the venous phase, are nonspecific and are not used to diagnose PE. Once a thrombus is identified, the study should be terminated. The only exception is when a patient is considered a candidate for surgical thrombectomy or thrombolytic therapy, where precise knowledge of the laterality, location, and extent of the thrombus is required. The overall complication rate of pulmonary angiography is 2 to 5% and can be divided into those related to contrast administration and those secondary to cardiac catheterization and injection of intrapulmonary arterial contrast. Mortality from pulmonary angiography is less than 5% and less than 0.5%. I'm sorry. And is usually related to sudden right ventricular failure from transient elevation of pulmonary arterial pressure secondary to contrast injection. Death from pulmonary angiography is seen almost exclusively in critically ill patients and those with pre-existing severe pulmonary arterial hypertension or those patients with right ventricular dysfunction. However, there is no significant increase in the incidence of major non-fatal reactions in patients with pulmonary arterial hypertension. In addition, the majority of patients with severe right ventricular dysfunction have uneventful studies. When one considers the added safety of selective contrast injection using non-ionic contrast agents and the high mortality of untreated PE in this population, pulmonary angiography should definitely be performed in these patients when clinically indicated.